and we were talking about, so we've got some type of infection that we're working with, right? And we're playing like we're the lab people, right? And so once, as an MA, we get our culture, or whether it be from a wound, saliva, urine, vaginal, nasal, whatever, we send it to the lab, and the lab does its first few things of, you know, gram staining it, putting it in a petri dish that has agar, checking it underneath the microscope to see if it has organelle, checking its morphology, right? Everybody should know that word. And then what's the other things that we're going to start doing? We're going to start getting, now that we've got this narrowed down, we're going to get to the mystery. All right. We're going to start asking the questions. All right. But the lab is going to rely on the questions that you asked your patient. All right. Like, um, when did these symptoms start? All right. What were the first symptoms? Did you have, you're going to have to do a lot of investigating questions. So if they said about a month ago, and you'll say, well, how did it start? Maybe it's a wound. How did it start? Well, it started like with a little ulcer. All right. And they say, well, was it itchy? Was it raised? You're going to investigate. You're going to try to get to the bottom. Were you scratching at it? Had you come in any contact with anything that could have possibly caused infection? That kind of thing. So, because if we're to this point of, sending a culture out, we really need to figure out, well, what could they have come in contact with? How many of y'all ever watch House? We're not going to go as in depth as House, but we're going to want to find some clues, right? Now, here's the problem on our end as the MA. People, when you go to the doctor, what do you want? You want to feel better and you want answers, right? But guess what? When we do blood work, when we do a culture, when we do a lot of specimens, you're not going to be able to get that immediate answer. And that's something you need to relay to the patient, okay? So that they're not sitting around and they're not like, oh, I still don't know, or worried. Let them know. Cultures especially, it's usually going to take about 72 hours for something to be incubated, once they inoculate it, and then for allow it to grow. Now, some bacteria do move faster, and it could be like within 12 to 24 hours. But for the most part, it's a couple of days, okay? So make sure the patient understands that. Just like when they go for, most routine blood work, it's a day or 2 days before they have their results. So make sure they know, make sure they understand, and make sure that when the results do come back, do we ever, say that comes off the printer and LabCorp says, oh, okay, they've got, necrorizing fasciitis. Do we call the patient and tell them that? No. The doctor has to review any lab reports, any blood reports, any diagnostic testing, anything, because we are not doctors. We do not diagnose, and we do not give information to our patients unless it has been approved and okayed by the doctor. Now, my PCP back in Texas, many times he would go through, he would review the lab work, everything looked normal, or, oh, hey, your iron was still really low, your B12 was really low. And so then his medical assistant would call me and say, Miss Scalf, okay, Dr. O's reviewed everything and he wants you to increase your iron and B12 and blah, 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 whatever. But all rest of the tests were within normal limits. And like, okay, cool. You have a fracture. Doctor looks at the x-ray. Oh, yep, sure enough. Big toe's fractured. So go ahead and call Miss Jones and tell her, yeah, her toe's fractured. She needs to see an orthopedic surgeon. So that would be something, but never unless you've been given that okay by the doctor, okay? Now I gave you all an amazing video on cultures. It showed you how to obtain the culture. How to make sure that we kept the culture sterile. That make sure that we give the lab the absolute best specimen that we can. And everybody should have watched that video by now, okay? Now, some specimens, and are you going to be able to know this? No. This is going to require people who have experience, who've been working in the office, or the doctor themselves telling you, hey, as soon as you get that culture, I need you to put it in a dark bag. Or, hey, as soon as you get that culture, I need to put on ice. Or as soon as blood work, those kind of things, you're not going to know special procedures. So always ask, hey, is there any special procedures regarding this culture? Most of them you're just going to stick them in the fridge, the lab fridge, okay? And that way that keeps their integrity, all right? So the next thing we're going to talk about is antibody resistant and growth zones. And this is kind of cool, and I do have a very cool video I'm going to show y'all. We now in the lab, sorry, my son. So now we're back to the lab technician role, and the we're playing that person. So we've got our petri dishes, right? And not only when they take that culture that you sent them, this is why they need a really good specimen. They're going to find out if it needs a auger, remember, and a base to lay on, its carpet. And if they do, then they'll inoculate. It's called inoculating. They'll inoculate one petri dish, and that means wiping the bacteria all over the petri dish. And then they're going to use rest of the culture for what we call an antibody sensitivity testing. And they're going to inoculate that petri dish. Okay? And then that's where now let's see if anybody can answer this. I'm going to be just massively impressed because this means you've been listening to me. So here we have a petri dish. Can anybody tell me what auger that is? And if you're typing, I can't see it. You're going to have to speak to me. Nobody? My son's coming to answer. Don't let him beat y'all. What would that be?
I actually don't know this one.
Oh, you don't know. Well, blood. It's blood. It looks like blood, right? So this is be a blood auger. This would probably be a gel algae based auger. There's different types of augers, right? So there's blood.
I was gonna say it.
See, you should have said it. You always go with that instinct. Ah. And so we see here that it's hemolyzed. So it hemolyzed in a blood-based auger. So that gives us more clues. All right. Now that other inoculated petri dish, and see, the inoculation starts. You see, they did this one good. Whoever inoculated this, they got the substance They swabbed it so well. It's on corner to corner to corner to corner. They didn't miss a single. See that right there? That's a good inoculated slide. And if you ever take micro, you'll realize getting a perfectly inoculated slide's not easy. Now, what is this that we have in here? Those are antibiotics. So, now this is a part I really need y'all to listen to because this is Micro 101, the whole basis of why we as MAs send our cultures out to find out not only what it is, but what drug is going to get Miss Jones well fast. So, how that's done is here's Mrs. Jones' wound culture. And then each one of these tablets, and you see they're numbered and named, is a specific antibiotic. This could be penicillin. This could be sulfur. This could be zithromycin, and so on, right? So they're going to take what they feel would be like the top antibiotics to use for what they think the bacteria is. And they're going to allow it to grow. Now, this is a let's look at this and think about this, okay? If an antibiotic is really effective, and this is Mrs. Jones's bacteria, is this antibiotic effective? No, because that bacteria is all up in that space, right? It grew all the way up to it, like, yo, hey, how you doing? Now let's look at this one. This bacteria says, hey, back up out of my bubble, right? And it's got a pretty good resistance. These all got about the same. This is, I'd say, second best. But which one stands out and tells you, I am the antibiotic you want to give Miss Jones? Which one?
The CTX30.
Yes, because it tells you not only back up out of my bubble, but give me 50 feet too. Get up, move it, right? So it tells you, I am going to go in there and I am going to get rid of Mrs. Jones' infection, plain and simple. So this is an amazing test because it, like I said, it not only now do we know, hey, what does Miss Jones have? Now we know which medication, because maybe we've had her on 2 or 3 and they didn't work. Like it was something like these, right? They weren't just strong enough. But when you pop her on this is the magic medication. Make sense? All right. That's called antibody sensitivity culturing. Okay?
I never knew that. That is really awesome.
Yeah, when micro, I can't. I'll geek out on y'all if I start talking about micro. Micro is one of my absolute, favorites. My daughter is going and she's doing micro, but she's doing micro along with the specific study of viruses.
Oh, that's
So
awesome.
yeah, and
They
that's
call
what
it viral.
Yeah, it's virology. So she'll be a microbiology with a microbiologist with a expertise in virology, and she would like to work with epidemiology, that kind of stuff.
Oh,
So
that's awesome. Save the world.
yes, yes. So we see the importance of that's the whole reason we moved to Florida because UCF is actually one of the top schools in the nation for micro and virology. So that's why we're here. So she got a scholarship. She's my smart girl.
Congratulations.
Thank you. So We're going to go back to MA role now. So that MA role is you see how important, or you should see, when you're collecting that sample, when you're getting the proper amount and doing it the proper way, like it was shown in the video, and that you're making sure it keeps its integrity, meaning that it does not get cross-contaminated with anything else. That's why urine samples sometimes can be a pain. You ladies, I'm sure everybody's done a UA. That's what we call a urinalysis. So a UA, there's two types. There is a type where you can just go in and just pee in the cup, right? And then there's one that's called a clean. Go ahead, I need somebody to mute their mic. We've got a windstorm. Okay, our windstorm's gone. Uh, we've got another type of urinalysis culture, and it's called a clean catch. All right, and that's where they have you. They want you to get 3 wipes, and I actually have a video, and it's y'all might have seen it when we did, where you have to wipe one side of the labia and the other side of the labia, and then down from the front to the back, and then hold everything open, then pee a tiny bit, and then somehow magically get that cup in there to catch it, right? So that's called a clean catch, and those are great, but they're still not the best. When you're gonna when you get a, what do you call, there's another better way, and that'd be Foley. That's where we take a tiny catheter and put that catheter directly into the urethra, and it'll stimulate the bladder. We get urine that way. That's a pretty positive way. But then there's another way, and it's called a suprapubic, and that's where they go in and they take a large needle and draw the urine directly out of the bladder. But that's only usually done with medical emergencies. Okay. Now,
Question.
Uh-huh.
What medical emergency would that be that they'll have to do that?
If I've witnessed it with really bad things like severe vaginal mutation, somebody or mutilation, where somebody was raped or abused, somebody was burnt, their genitalia was disfigured. I saw it with a car wreck. I've seen it, but like burnt, like I said, a burn. So there's been a couple of reasons that I've seen them do that. But like I said, yeah. So it's not something that they can easily access to get a Foley from. But the whole reason that we get samples, and the whole reason as a medical assistant that we want to maintain the integrity of the culture is, and we do this by quality control, and it's QC, right? And every single test has its own specific quality control. And then, of course, we learned about universal precautions and universal this and that. And of course, we're going to maintain all of those same standards at the time. But just you make sure you understand that each test could have specific other guidelines that you need. Does that make sense? Like certain wounds, the doctor might tell you, I need you to go in and say if it's a couple of inches deep, I need you to go in the full 2 inches. He might give you specific instructions, or maybe there's a little crust over it. I want you to remove the crust and get into the wound. Or I need you to make sure Mrs. Jones gets you a proper sputum specimen. So you might have to get her to where she's not only coughing, but to the point to where that she coughs up phlegm from the lungs. You understand what I'm saying? So there's multiple different scenarios where the doctor might give you specific instructions. And then we've already seen this video, and this is the typical culturette. This is one of those. This is what they're using right now for the coronavirus. Something very similar to this. They put it up in there. They get a good, and now they've actually just approved a saliva where you can just spit or drool into the cup, and within 3 hours they can get a result, and it's almost got like a 99% accuracy. So it's a much less invasive procedure. The the patient's not as discomforted. Now, this could also be used for this one. To me, looks like something they use what they do the nasals for flu cultures, or this also could be like a strep culture or inside of a wound culture. There's all kinds of different ones, but they usually all have the cap, and this will be taped together. So you'll break that seal. So when you break that seal, do you ever want this area to touch anything but the wound or the place you're getting your culture? Nope. You do not want it to touch the table. You don't want it to touch a piece of skin or anything like that. You want it only coming in contact with what we're culturing. And then at the moment we're done, then we go ahead and we place it back into the culturette, and you see there's a medium, and a lot of times this medium is there to preserve, to keep the culture from disintegrating or becoming bad. And then we always either place the patient's information, and a lot of places now have just gone to stickers where we just put their labels on it. Okay. Throat cultures. Now, I showed you a great video, and it talked about, and I loved that video because it was the only one that I found that talked about not only do you go, you always start at the side where you see the pus and so forth, in case somebody starts to gag on you, right? And so you get a good culture and you roll it across the area. But that video also talked about how you sweep the arch and then you get the other infected side. All right. And so that's why I really, like I said, if you haven't watched that video, please make sure you do. Okay.
Question.
Sputum. Uh-huh.
I've done throat cultures before,
Hmm.
and they've never actually told me about the arch.
Yeah, I
You
know.
actually swab the arch. They usually, they say the side of the mouth or the tonsils or wherever there actually is inflammation or the infection at. But swabbing it from one side to the arch and to the other side, does that spread the infection if
Well,
it hasn't gone to that area?
the infection, and then the whole thing with it, if one side's infected, it's just the side that's taking the blood, but the whole area is already infected. It's in your mouth.
Makes
So
sense.
yeah, you've already have strep. You already have tonsillitis. You already have maybe fungal. Whatever it is, you have that. And just because one side's more infected than the other, that just means that that's the side that's caught it, maybe, and is
Right.
working really hard. But they both have it. And the reason we do get we don't, of course, we don't want to mess with their uvula. That'll gag somebody. The reason we get that arch is sometimes um, if especially when we don't see like pus pocket, maybe it's just really, really red. A lot of times with strep, the reason we do that is strep will it'll cover the entire area, the entire, and grabbing that arch is just an additional way of making sure if we don't miss anything. All right. Um,
Okay.
yeah. So, and that's how I was taught when I did it. And it's, but yeah, like you said, most now, hey y'all, and remember this. I've said this a million times. Now you may go someplace and they say, "Oh no, we don't do that." And what are you gonna say? Okay, and you're going to do whatever the way they told you. If they just want you to get a culture of the infected tonsil, that's what you do. If they say get this tonsil and then get that tonsil, then that's what you do. Whatever, wherever you go, because MAs were fluid. And but if you're given the option, just like with the EKGs and the different things, I have my ways, and most of the time when I'm telling you my ways, it's because this is what I've had doctors, professionals, and stuff tell me. Hey, this is what we kind of prefer. This is the better way. All right. But like I said, always go with what your doc tells you. Now, that I do have to put a limit to that. Don't ever do anything that you do not feel comfortable doing, or you don't ever have to do anything that you feel puts your patient or you at risk. Okay. So that's where you can draw the line. But you can do it in a respectful way. But that's just more general information. Sputum samples, ugh, I have bad medical paramedic stories with sputum. I can't even look at it. Sputum samples, I'm serious. Yeah, you don't even want to know. Um, Sputum samples have to be something that not just a drool, not just a spit. It has to be something that's coughed and it's brought up. You see this a lot. I can't even see I don't even want to look at the picture. You see this a lot with uh, chronic bronchitis from COPD, stuff like that, or even acute bronchitis, pneumonia, that kind of thing. The other place that you see it, and this is why I have to keep the picture covered, is you see this a lot with trachs. And if you have a patient who has a trach, you'll see a lot of excessive sometimes sputum and sputum to where when you change the trach plug or hook up to there's a um, outwardly
Build up.
flow and pressure release of sputum. So we'll leave it
Yep.
there. Please, 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 if you ever deal with a trach, put on a face shield. Please. That's all I'm going to say about that. We're going to pass. We're going to move on.
Ew. I can only imagine it just coming
Ah,
at
yeah. It was not a good day. Um, Wet mounds are another way that we can prep a culture. So say you're working for a gynecologist and the lady comes in, she's like, I got some itching downstairs. And the doc says, well, let me just take a look real quick. So he gets a little culture and then he hands you the culture and says, go prepare this for a wet mound. And basically all you're doing is you're putting a drop of whatever sterile solution that they use, usually just like sterile saline, sterile water, something like that. You drop a tiny drop on it um, after you've inoculated the glass slide. And then you slowly place this, it's glass as well. It's a little slip cover. Don't let it just flop down or you're going to spread your culture everywhere. You slowly let it pull it down. You can use tweezers or something like that to assist you. And what it does is it puts it into a suspended. One of the main reasons that we do that is if we're looking at something protozoa or something uh, that has, God, what is it? Trick? like trichomonas, the STD, or we could also see yeast. We could also see all kinds of things. So the doctor will sometimes want to view it right there at the lab. So he'll go, oh, I see what's wrong, and go in there and give the patient the proper medication to get rid of whatever it is. So this is something else, and I'll post a video for y'all so y'all have that hands-on look of it. Okay, it's not hard. It's just going to be like taking the culture swab, rubbing it all up and down in the center of the glass slide, adding the drop of sterile solution, and then slowly putting the slip cover and then setting it on the microscope for the doc. Now, I have had MAs that come back to me and tell me the doctor said I was supposed to be able to recognize and look at under the microscope. No, that is not your job. That is not what you were paid for. That is not what you were trained to do. You are not a microbiologist. You are not a doctor. Do not let them come back at you with that. Now, I have had other students that come back and say, Miss Galv, one girl, she works for a gynecologist, and she was just like, you're not even going to believe. This doctor's so cool. He showed us how to do the microscope. He showed us how to look for white blood cells. And because like sometimes urine will have a large concentration of white blood cells. He showed us how to look for the crystals and all this different thing. I was like, that's awesome. All right. Now, and a lot of times docs will do that. They'll show you and they'll train you how to do certain things. But if nobody's ever trained you like that, and then they tell you, go tell me what's under the sun, I'll say, that was not part of our training as a medical assistant. Could you assist me? And of course, you do, like I said, respectfully, but let them know and never be afraid to say, that is not something as a medical assistant I was trained to do. Okay. But lo and behold, don't let me ever find out that you say, oh, I was never trained on how to prep a wet mount, because you'll be having me giving you the look. Okay. Here's the fun part, right? Woohoo. I should have did a breakfast warning. Stool samples. So we get stool samples for many reasons. And right now we're going to focus on that ova. What is an ova? It's an egg. And we're going to...
Egg.
Yep, egg, yes, and parasite. Eggs and parasites. So a lot of times, little kids and different things like that will... You'll even have that one mom bring in the baggie that has the poop in it, and you can see the little eggs and the dead worms in it. Like, little Jimmy's got pinworm. Hey, good job, mom. Thanks. Now I ain't gotta mess with that. But then other times they'll tell the patient, take this home and get a little thing like this, have little Jimmy poop in it, and then they'll use the little sample slide and put it in there. Sometimes, I'm just warning you, usually this is just sent off to the lab. Pray to God it is. But other times the doctor will have you prepare a slide to look under the microscope. And when you do so, stick some, I'm dead serious, because you'll be in the lab, nobody's going to see you. Grab some tissue paper and shove it up in your nose like this, and then prep your slide with the poop, put the little slip cover down over it, set it on the microscope, ready for the doc to come in and take a look at it. And make sure you take the toilet paper out before you leave the room. And then you can cover up and close the stool sample again. But we do work with poop. We do work with pee. We do work with vaginal fluids, semen, sputum, blood, vomit. So it's just part of the job. Now, stool specimen for pinworms. And I kind of mentioned this the other day, and that's what I forgot to do. I forgot to post that video. Brian, write that down on your board. Video about sputum and video about stool oviparasite or pinworm. Okay. So with pinworms, I talked to you about how they're nocturnal and they like to party at night, right? And one of the ways you can you say your patient calls on the phone and says, "Not sure if we need an appointment or not, but little Jimmy's been saying his booty itches at night." So you can tell, well, we're going to set you up an appointment, but before that, what you can do is tonight get a flashlight and look at his anus. And a lot of times you can see the little worms come out at night. And another thing the doctor might even tell you to do is tell the patient, get a piece of scotch tape or tape and actually stick it up on the booty hole and pull it out and stick it on like a piece of saran wrap or a baggie and then place that in there. Because what that'll do is it'll pull some of the ova or actual worm with it. Okay. The tape test sometimes has to be done 3 different days to make sure. Sometimes they'll even do that after treatment to make sure it's cleared up. I am so sorry. This is a very close up of internal pinworms. Okay, so this is them during the day. They're hiding out inside the rectum. This is them at night. I told you they come outside to party at night. And that's what I was telling you, that they are white, they are visible, and they're very itchy because you can like feel them squirming. And then this is showing the tape test. Somebody has taken a wooden like tongue depressor and wrapped tape around it and then spread the cheeks and that's another way to do it. With Brian, when he had it, I just had his sister hold his butt cheeks open and took a piece of tape and went in there and and just, he was what, 3, and then I slapped it on the baggie, put the baggie in a baggie, and took it in there, and it's like, he's got pinworms, doc. And now I realize, why I'm looking, and they're all like, oh, thank God, because they didn't have to go in there and look for it. So it's called a tape test. Okay. It is 40 minutes, so we're going to stop before we go any further with group A and strep testing. But I've already posted a couple of, I think 2 videos